Immune-based therapies are proving to be a major step change in the outcomes for patients with multiple myeloma. Particularly CAR T-cell therapy has been associated with a significant prolongation in progression-free survival and overall survival. However, despite these very exciting results, unfortunately patients are continuing to relapse, which means that in the majority these treatments are not yet curable. So what I've been talking about is how do we harness the rest of the immune system to try and augment the responses that we are seeing with both CAR T-cell therapy and bispecific T-cell engagers. Because the immune system is actually a very complex system, and the bits that we're not thinking about are things like antigen presentation, myeloid suppressor cells, as well as NK cells and other components of the immune system. One of the things that we're now understanding is that the immune microenvironment prior to commencing these treatments is predictive of whether or not you will respond to treatment. And essentially, you can look at the T-cell profile. If patients have exhausted or a narrow T-cell repertoire, they're unlikely to respond to T-cell immunotherapy. We also find that the phenotype of the plasma cell is important. So if you have a more mature plasma cell phenotype, you will respond, whereas a more biologically immature phenotype, you won't respond. The other interesting factor is that MHC class 1 expression appears to be important, because loss of MHC class 1 can deregulate the interaction between the T-cell receptor and the plasma cell. And interestingly, radiation therapy invokes MHC class 1 expression, and we think that that may augment it. So some of the data that's coming out is with the new cell mods, and these are new drugs such as Iberdomide and Mezigdomide that can inhibit cereblon and augment the immune system. And what we found was that Mezigdomide can enhance T-cell infiltration into tumor cells. And this becomes really important because what we know is that patients with extramedullary disease and plasmacytomas don't respond so well to immune therapies. And so if Mezigdomide is able to improve the trafficking of T cells into plasmacytomas, and then you couple it with a T-cell engager, then that lays the foundation of augmenting immune responses and better overall outcomes. And so really what I've been talking about is giving a cell mod in combination with these immune therapies to try and improve outcomes. One of the problems, however, is the toxicity with this, and so we have to work out what's the best way of scheduling it to understand it.